God when I'm in awesome wonder. Consider all thy works thy hand doth make. I see the stars, I hear the mighty thunder. Thy power throughout the universe display. Then sings my soul, my Savior God to thee. How great thou art, how great thou art. Then sings my soul, my Savior God to thee. How great thou art, how great thou art. When through the woods, the forest glades I wander, and hear the birds sing sweetly in the trees. When I look down from lofty mountain grandeur, and hear the brook and feel the gentle breeze, then sings my soul, my Savior God to thee. How great thou art, how great thou art. Then sings my soul, my Savior God to thee. How great thou art, how great thou art.
The introduction of the team from MotecLife-UK.
Thank you very much. How do I start? How are we going to finish it? I must say I'm happy to be here with my team from the UK. My name is Koforidua. I train in the medical school here in Ghana, Koforidua, and had my veterinary training in the UK. Some members of my group will actually introduce themselves one by one, which will be easier. On my Caroline Hing, ex-orthopedic consultant at George's Hospital. This is your second visit to Ghana.
Yeah, I enjoyed it so much the first time I went back.
Yeah. She organized, she was part of a masterclass in trauma orthopedic teaching at Kosovo in 2010, I suppose, 2011. Yeah. And it went down very well. We have a small number to start with, but who knows? We might get it. Next to
Hi, I'm Amy, I'm a physio, and I work in the south of England. And my uncle came out a couple of years ago and pulled some out, so I came out.
So we welcome all of them. And next to that,
Hi, I'm Lauren. I'm with the Junior Doctors in London.
London, St. George's Hospital, the two of them are from the same hospital.
I'm Andrew Irwin, really pleased to be here. I do trauma surgery and general orthopedics, but specialised in the last few years in shoulder and elbow surgery. And I'm really excited about visiting Ghana. Thank you.
Last but not the least.
Hello, I'm Catherine. I'm still a student, but I'm applying to do medicine. So hopefully I'll see if I get in.
Clearly, as Dr. Rahman pointed out, Motec did everything for this workshop to be organized. And we being the host St. Joseph Hospital, have been tasked to welcome all of us to start this workshop. And I want to say it is with great pleasure that we are all here for this workshop to be opened through the will of God and by the efforts of Motec and all of us who have been able to come. The representative of the Regional Director of Ghana Health Services, we want to welcome you. I'm very grateful for the support and acceptance to be part of this workshop. The director, we know he's always very busy, and we cannot really begrudge him for his absence. And we know he is with us. That's why he has sent you to be part of this program. A very well welcome to the facilitators from the UK. they have sacrificed the luxuries over there. And they are here to share their knowledge and experience with us at this time when perhaps the sun is somehow friendly. We're not getting the heat as yet. So we are grateful and wish you a happy stay in Ghana, particularly those of you who are going for the first time. To our participants, I know some of you are coming not from this here, but far away. With the bad news, you have sacrificed to be here. We welcome you to the Flowers City, as we normally call it, Koforidua. For some of you, it is your first time. We want you to feel at home, enjoy the serenity and loving nature of the people of Koforidua, the traditional area. We are here this morning and tomorrow to discuss fracture management. This is because our part of the world, there are undesirable effects on fracture victims in their families. The victims are mostly the breadwinners of their family, making it very crucial for healthcare givers like we to render optimal quality care to help them get back to normalcy. Indeed, majority of these victims or these fractures do occur through road traffic accidents. But in Ghana, unfortunately, there are a limited number of specialist institutions in orthopedics and trauma. Therefore, most of these victims are transported to the district health facilities where they are compelled to do what they can with the little resources available to manage them. Indeed, my understanding of early fracture management is to control hemorrhage, provide pain relief, prevent ischemia, reperfusion injury, and remove potential sources of contamination. Thus, the goal in managing fractures is to ensure that the involved limb segment, when healed, has returned to its maximal possible function. And I'm sure it is the reason for which we are here. Therefore, I find this workshop very appropriate as it seeks to delve into fracture management, building capacity at all levels to improve fracture management to our patients. I am encouraged by the response and willingness to participate in this workshop. It is a good sign indicating how we take health issues very serious, particularly in the area of fracture management. It is my prayer and wish that such events will eventually become perhaps a biannual activity so that we can achieve our objective in reducing complications resulting from inefficient early management of fractures in our health facilities. The facilitators, I'm sure, and perhaps they have already promised to make this workshop very educative and exciting. The weather is cool and comfortable, and I hope you will enjoy your stay for the workshop. I welcome you to this important workshop. Thank you.
Good morning. I'm Dr. Kwame Nimbuama, the Medical Director for the Regional Hospital, and I'm standing in for Dr. Macdonald Dejo, who could not be with us this morning because of a travel engagement. Mr. Hospital Director, Dr. Koforidua, faculty members from MotecLife, colleague, health practitioners, distinguished ladies and gentlemen, it gives me much pleasure to be part of this workshop today. It is gratifying to note the collaboration between the MotecLife-UK and St. Joseph's Orthopedic Hospital in sharing knowledge and skills for improved patient care. Indeed, medicine is a field of fast-growing knowledge, and it is important for practitioners to be abreast with updates in their various fields so as to be able to provide evidence-based care to their clients. It is in this regard that I find this 2-day workshop on open fracture management to be extremely useful. I therefore wish all of us participants and faculty a very educative workshop and urge participants to apply the new skills and knowledge that will be gained through this workshop to our day-to-day practice, so that it will not just be one of those workshops that we attend, maybe for some CPD points. So I wish you a very useful deliberation. Thank you very much, and God bless us all.
Fractures. The first speaker will be talking about fracture healing, processes involved. And indeed, I think most of us know about what fracture is. Fracture healing is no different from, should I say, making love. Two people come together, a little bit of movement, and it's a good union. That's what it's all about. So in your own life, you all have experience about how things can come together. And we're going to try to make sure we elaborate it scientifically. Yeah, it is true. I'll get you. So maybe because the life is going to be a view.
Types of fracture healing and the pathophysiology of this. Discuss the types of failure. Discuss the factors affecting healing and some of the treatment principles. So, real basics. A fracture occurs when bone absorbs a greater amount of energy under the mechanical loading than it can withstand, resulting in cortical deformity. And the essence of fracture healing is to completely restore the prior micro and macroscopic appearance of the bone without scarring. And as we know, this is completely unique to bone, as it's the only thing that heals without scarring in the body. So, I'm going to discuss the two types of fracture healing. So, we divide them into primary and secondary. So, primary fracture healing only occurs when it's direct. We must have anatomic reduction and absolute stability. And this can be given by rigid fixation, so compression plating and lag screws are the only things that are going to cause direct primary fracture healing. And secondary, the most common, is caused by indirect, non-absolute stability. So occurs when we have semi-rigid, non-rigid fixation, such as X-fixes, intermedullary nailing, and bridging plates, or I suppose casts and traction. So firstly, a little bit about primary fracture healing. So as I said, absolute stability and zero strain on the fracture site. So this means there's minimal action at the fracture site, which will allow the initial fracture hematoma to be reabsorbed and let the swelling subside. And this is called I'm going to say this wrong, Bayesian remodeling. So we have osteons, and at the tip we've got osteoclasts, which remove all the dead bone, and behind that we have the osteoblasts, which form new bone, which is connected to the capillaries. So we form a bridge over the fracture gap with new bone, finally remodeling. So I'm going to go through all of those in a little bit more detail. So firstly, after the fracture, the hematoma forms by a rupture of the periosteal and endosteal vessels, plus also some soft tissue trauma, which will cause the hematoma. So blood fills at the fracture site, which causes a regional hypoperfusion, which causes a decrease in oxygen tension, a decrease in nutrients. So the osteocytes die, which leaves the end of the fracture sites without any living vessels, living cells. So, unless obviously there's adequate collateral circulation to continue to supply the fracture site. So this then triggers the coagulation cascade, and at the hematoma we get platelets, macrophages, which then release cytokines, so platelet-derived growth factors, interleukins 1 and 6, and some prostaglandins, which then cause the inflammation. So we get inflammatory mediators released from the hematoma, and obviously released from the necrotic cells and the living injured cells from the surrounding soft tissue. We then get a dilation of the blood vessels, increased vascular permeability, then causes a migration of further inflammatory cells and further cytokines, which cause the activation of osteoclasts, which reabsorb the necrotic bone and the debris around. Then further, we get the migration of the fibroblasts, so we convert the hematoma into granulation tissue, the new fibrin matrix, where we get capillaries forming as well. So further to that, we get the migration of the osteoblasts, which are going to form new cells. So they're primitive mesenchymal cells, which then proliferate and differentiate, which form callus to bridge the new fracture site. So then we move on to the ossification stage. So the fracture hematoma, as we said, then causes the inflammatory stage, which causes the granulation tissue. We then need to go on to the cartilage matrix, and then obviously the bone matrix. So we've got two types of callus, soft callus and hard callus. So the soft callus will then differentiate from the granulation tissue to cartilage. We get type 2 collagen, which then we increase of osteocalcin, which then produces chondrocytes to undergo apoptosis, and then get a new extracellular matrix of type 1 collagen, which is the osteoid, and then get calcification of this, so the bone replaces the soft callus. We've then got the hard callus, which is the intramembranous ossification, and we get an early synthesis of the osteocalcin, so we kind of skip one stage and end up with a new extracellular cellular matrix sooner, and calcification, and again the bone replaces the hard callus. So finally, we enter the remodeling stage, where we have our disorganized, mineralized woven bone must be remodeled to withstand an appropriate force. So it's replaced by lamellar bone, which is ordered microarchitecture. We get rid of all the excess bone and provide strength along the stress lines. So we change the bone structure, so to the mechanical stresses that are going to be placed upon it. So that is fracture healing. So fracture union, there's two things we can talk about. Clinical union, which is where you have pain-free stability at the fracture site, and radiological union, where on plain radiographs you see the trabeculae cortical bone crossing the fracture site, so you can actually see the bridging of the fracture. So there's two types of failure of fracture healing. So non-union, so symptomatic fracture with no apparent potential to heal without intervention. So hypertrophic, where you've got hypervascular state, so there's more biological potential to heal with further fixation, relocation, stability, etc. And atrophic, where there's hypovascular, so less chance of healing. We've got a delayed union, which there's lots of different definitions of it. I like this one best. A fracture in which healing hasn't occurred in the expected time and the outcome remains uncertain. Obviously, it's very specific to depending on the type of fracture, where the fracture is, what methods you've done to promote healing. So you can't put a time on it depending. And then finally, a pseudoarthrosis. So a painless fracture that's failed to unite and has no potential to do so. It's just some pictures of hypertrophic. So you can see lots of the callus formation around it, and the atrophic, where you see minimal callus. So then we're going to look at any factors that affect Can anyone give us any factors that might affect? Anything to shout out? Go for it. Yeah. Anything else?
Infection.
Yeah, brilliant.
Foreign body again.
Yeah.
Imposing patterns.
Anyone else? So, age. Healing decreases with increasing age until you reach speech maturity, and then after that, it's not really a factor. Nutritional status. For bones to heal, you need a steady supply of protein and carbohydrates, and you need an increased metabolic rate. So you're not going to get appropriate factor healing when someone is have any dietary deficiencies. So you need to make sure someone is appropriately has the appropriate nutrition and well-being for them to heal effectively. Any systemic diseases, diabetes is one of the most common that causes delay in healing. Any drugs, so immunosuppressives and non-steroidals also affect fracture healing. And then other smoking and alcohol we all know. Local factors, so how the fracture occurred, was it a high energy impact? Is there lots of soft tissue damage surrounding the fracture? Is there lots of bone loss? So we're trying to bridge a bigger gap. And is there open fractures? And obviously with open fractures, you think about infections. And if we've got infections, we've got cells who are then trying to deal with the infection rather than deal with the fracture healing. So we know that local cells need to be devoted to healing. As with infection, we cause necrosis of the soft tissue, lots of edema, thrombosis with the blood vessels, so then the supply is worse, so healing is less effective. Again, different fracture locations, so where the fracture is, may affect the blood supply, effectively impacting that way. Again, fracture type, we've got lots of convoluted, we've got multi-fragmented fractures. We've got a poor local blood supply. This could be because we've operated and have disrupted the surrounding tissues, disrupted the blood supply that way. As you said, have we got anything in the middle of the fracture site? So do we need to do an open reduction and make sure the fracture site is completely clear and we've got fixation that way? Again, how are we going to manage them post-operatively? We're going to load mechanical loading onto the fracture. Are we going to keep them not loading? Is that going to affect healing? Yeah. Obviously, as we said, fixation and different methods will affect how it heals as well, especially, as we said earlier, whether it's going to be primary or secondary healing. And just a quick thing about pathological fractures. So, pathological fractures due to infection, they're going to heal when the infection's been cleared. So, it's going to heal normally as soon as we've cleared the, well, hopefully as soon as the infection's been cleared. If a pathological fracture occurs because of a tumour, it's probably going to remain ununited, so you need to create stability with your fixation method around that. And Paget's disease delays fracture union, but they normally unite after a long period of time. So obviously diagnosis, as we would normally do, we would assess your patient, taking a history, whether there's any pain, what they were like preoperatively, what they wanted to get back to, their functional status, if they were doing work that they needed to be functional again with, and then obviously whether they've questioned them to see if they've had any systemic signs of fevers and things like this for an infection. Obviously then you're going to examine them, and look for mobility of the fracture and range of movement in the surrounding joints. And again, with infection, we're going to look for warmth and sinuses, and then look at scars, whether they're healed in a certain way that's going to reduce movement, whether it's not the fracture but any other factors. And then obviously shortening and lengthening of the limb or the fracture site. So simple investigations we can do, blood tests, looking for infection or evidence of systemic diseases. Obviously we've got our main radiographs, which can look for union, malalignment, further displacement, and the adequacy fixation, whether it's loosening or whether it's failure of fixation at all. And then we've got other potential further imaging factors to use in MRI as well. So our main treatment principles are to restore a pain-free function, that is the main aim for fracture healing, and to improve systemic features where possible. So I quite like these 4 S's. So we need to straighten, make the fracture aligned, we need to stabilise. So again, stability of the fracture site. We need to stimulate, so further debridement of dead tissue and mechanical stabilisation at the fracture. And then we need to sterilise, so remove any infected tissue, remove any infected metalwork, appropriate cover with antibiotics. And obviously, if there is any signs of complex or recurrent failures, then we need to refer to a specialist pretty early if they have a better outcome. So, in summary, we've got 2 types of fracture healing depending on the fixation method you choose and the types of fractures. We've got multiple fractures we've been over that affect fracture healing, and the best treatment for non-union is the prevention of it in the first place. That's it.
Any questions?
Okay, you can
Director of fractures in this country are treated without surgery. Mainly immobilization or forms of mobilization we have in this country. POP. Yeah, traction. How do our traditional healers immobilize fracture? You might know. Any idea?
Yeah, they use medicine and some wood, align, and then they tie it with a bandage. And then,
Is that not the same as applying a POP?
yeah, but
Effectively,
it's different.
it's like splinted. Yeah, they use herbs. They think the herbs is actually what is doing the job, but it's the other sticks around and the bandage that actually supports it. You know, we as humans have improved fractionally. Animals fracture, some will heal, others die. You have to go long distances to get water, and they can't move. They die. So we want to make it a bit better. I think the next talk. Now, if you fix a fracture, how would it be? You stabilize the fracture. She spoke about primary and secondary. You fix it. Is it going to be a primary pain or secondary pain? If there's too much movement, the fracture might not heal. If it's micro movement, it's likely to heal. What kind of metal? How is it going to heal when it's fixed and the gap is tight closed? It's by primary injection. If you apply a plaster, is it rigid? You can't get a rigid immobilization. There will be movement. And what kind of healing is that going to be? Secondary. So movement causes irritation of the tissues. You get periosteal stripping. You produce bone. So you get bone going across the fracture side as opposed to getting a tiny bit of bone between the two. So there's a difference. Nature applies the plate. If you hold it well, the plaster. Whereas if it needs fixation, biologically, you want to use the plate to hold it, and the osteocytes jump from one age to either fracture. So little scar when it's primary, and then long scar when it's secondary.
For us, medically, because people change their stories, as you can imagine. They say they slipped on a wet floor in a supermarket, and that will come later. You often go through the notes and find it was another mechanism of injury, but they're claiming for their injury. So it's very important to document what the patient tells you very early on, and to make sure that it's clearly documented, not just a scrawl like my writing. Whether it was direct trauma, whether it was a crushing injury, and of course, document whether osteoporosis is a factor. We are, I'm sure, as bad as you at making sure that we treat the whole patient. When they leave the hospital, we must alert the patient to make sure that they don't have osteoporosis and work out whether there's anything medically that we can do for that patient that might prevent them reappearing at a later date with other fractures. You don't have the problem maybe as much as we do because of your difference in diet, more exposure to sunshine, more harder working, but osteoporosis is very important as far as in our patients. Always examine the uninjured extremity. You'll fail the exam if you don't examine the normal side. And I always box the patients. I always start on the normal side in my clinic. And the patients say, no, it's not that, it's here. But I mean, it's very important to examine the normal side. Look for ecchymosis, swelling, and look at the characteristic shape of the bone. It's just a little bit of interest, a little bit of history here. Having Irish ancestors, it was interesting for me when preparing this talk to look back. We all know it's a Colles fracture, but who was Colles? And when did he live? It's an interesting anecdote that I found that while at Kilkenny College, there was a flood. And a local physician's house was flooded. Abraham found an anatomy book belonging to the doctor in a field and returned it to him. Sensing the young man's interest in medicine, the physician let Abraham keep that book. Obviously a very important moment. He went on to enroll in Trinity College, Dublin in 1790 and received the licentiate diploma in the College of Surgeons in 79, and then he went on to study medicine at Edinburgh, receiving the MD in 1997. And then he had multiple interests, as we know. We know about the Colles ligament, we know about the Colles fascia, but it was in 1840 he wrote the paper on the fracture of the carpal extremity of the radius. and it's still, as we know, known as the Colles fracture. And he described the distal radius fracture, and it was way ahead of his time. He did not have X-ray. I mean, that's an interesting thing. He didn't have X-ray to define this injury. He also described the membranous layer of the subcutaneous tissue of the perineum. He retired in 1841 and died in 1843 from gout. That's on the X-ray that we all know, and it is one of the most satisfying fractures to treat if we can get them early. If you can increase the deformity under image intensifier or even in casualty, reduce it under a hematoma block or a regional block, or even with sedation and pethidine, these patients are enormously grateful. But what we'd also like to do is maybe discuss some of the more complex fractures. And it's the intra-articular fractures that are the real challenging ones, or the open fractures, as we all know. We classify them as intra-articular, extra-articular, open, and comminuted. The C3 and the comminuted are very difficult to treat. Like Colles, we know about Smith's fracture, which is the angulation and displacement in a volar direction or in a palmar direction. And he came close behind Colles, and he was another famous Irishman. He was an Irish surgeon and pathologist who described Smith's fracture in 1847 book, the first important book on fractures by an Irish author. He studied medicine at Dublin, and then in 1942 he became a fellow of the College of Surgeons of Ireland. He became the first professor of surgery at Trinity in 1847. And interestingly, in his treatise in 1847, on fractures of the vicinity of joints, he corrected his colleagues describing the Colles fracture, stating that the situation of the fracture is not so high as Mr. Colles states it to be. I have never seen it more than an inch above the carpal end of the bone. In the majority of cases, it is not so much. And there is a typical example of the fracture, probably as a result of landing on the wrist in a slightly more flexed position with compression. So there we have the worst combination. Frickman has his classification, which we can all look up, where both bones are involved. And that's more complex and more difficult to treat. To maintain the stability in this sort of fracture, very much more difficult. You can get away, if it's fresh, by manipulating and holding the patient in that dreadful position of the above elbow plaster with the wrist dorsiflexed. But you have to be very vigilant, and they're difficult to hold. And that's where we all know about the plating options, and we'll discuss that in a minute and have a round table and discuss your experience as well. Then, of course, the next chapter came along was Barton, who advanced on it even further and talked about the intra-articular. And the Americans have to have some input, not all the Irish surgeons. And that was John Ray Barton, born Philadelphia. We worked at Pennsylvania Hospital, 1823. And he's known for the Barton's, as well as Barton's fracture, as well as the figure of 8 bandage. What's fascinating reading about all these giants in medicine is that they were interested in many things. They weren't just interested in their particular area. They all had a very observant nature, and they contributed to medicine multifactorially. They didn't just stick to one particular area. And I've forgotten about Barton's obstetrics forceps, but he was famous for that as well. And there's the grumpy man himself. And there is a typical intra-articular fracture with displacement and multifragmentary. That fracture, if it's left untreated, will result in that dreadful carpal shortening where the lunate migrates more and more in a palmar direction, and they'll get that great dysfunction because you won't be able to keep the fracture out to length. You've got the ulna acting as a strut laterally or on the medial side, and you've got the radius shortening progressively. Get them early, easy to treat. Late, we all know, sticky, lots of callus, lots of scar tissue, very difficult to treat, very difficult to get led. People that are writing at the moment about this fracture, like Margaret McQueen in Edinburgh, always says, once you've missed a week, once the fracture's a week old, you're really on a hiding to nothing. You'll never really, by conservative measures, manage to pull that fracture out to its full length. If you get in on day one, put a Charnley slab on for a Colles fracture, nicely mold it, and then you yourself follow the patient up. We all know the results can be fine. The problem is we work as teams now, with hours, the European Working Time Directive. We're not allowed to work more than a certain number of hours, the little darlings, not allowed to, we've got to send them home. So the patient is treated by a different person every time they come. And the next doctor might have a slightly different approach to you, and he will not have the same vigilance and apply a 3-point loading slab, and then the fracture slips. And once it slips and heals, we are looking at osteotomy and much more difficult surgery. That's just a nice depiction of the various types, whether it's dorsally angulated, volar angulated, palmar angulated, or intra-articular. Dorsal, intra-articular, and volar intra-articular. The most difficult ones to treat often are the intra-articular dorsal. And that's where these locking plates may have a role to play. They are fairly rigid, but you can reduce those dorsal fragments and hold them with special screws, which we'll see in a minute. Another example of the various configurations of these fairly common fractures. That hasn't come out very well, but AO really revolutionized the care of fractures generally, and you can download the classifications from the internet, and we can discuss that at the end. Most of these fractures, as you know, are manipulation and plaster. The next thing to do is, if you're manipulating and plaster and cannot hold them, and you see them early on in the fracture clinic, catch them early. We can do minimally invasive surgery. There's some tricks of the trade that we will be discussing later when we're doing our X-Fix tomorrow and later today. Certainly, percutaneous pinning, Capanghi wiring or percutaneous pinning is the mainstay of a lot of these fracture treatments. I think the first thing we must always remember as part of the Hippocratic Oath, first do no harm. First do no harm. And we all think we're omnipotent because we've got a wire in the cupboard and it's sterile, and we've got a nice theatre to work in that we can make better. And there's no operation, as Jimmy Hutchison in Aberdeen always said to me, and would say to the patients in front of the doctors when we work with him, he's the professor there of orthopedics, there's no operation known to man, laddie, that will not make the occasional patient worse. And you've got to remember that. There's no operation known to man that can't make the occasional patient worse. So when we're using these wires, they are a vicious instrument, and they're spinning at high speed. And so gentle, meticulous handling of the tissues is so very important. There's no harm in elevating the patient's arm overnight. And I'm a great believer, having worked from numerous upper limb surgeons like Rolf Birch, Stanmore, and other surgeons that I really admire, not just bandaging the patient like this, because that's not great. Having a high sling, I always say to my patients, that's a good way of getting from A to B. It's a nice way to get home. But the minute you get home, please raise your arm there, on pillows, because these very basic things can make enormous differences to the patient's pain, decreasing the chances of any compartment syndrome and tight bandaging, and also allowing you access when you come to do your percutaneous pinning. You're doing your percutaneous pinning 48 hours after the original injury. The swelling will be so much Bradford type sling rather than truss-up like this. So I think that's a very, very good take-home message. Always try and advise your patients. First of all, they're scared because they've had such terrible pain, so they will not move. They will hold their fingers very rigidly, and there's no harm in telling them to start early movement once they're in their supporting bandage or supporting Charlie slab. Then if you're going to pin them, get the swelling down, get them to theatre, and another take-home message is don't just drive wires. I mean, I'm not telling you guys you would not do it, but always make a very careful hole with your scalpel blade, open up the tissues down to the bone, create a passage for your K-wire. Just have great respect for those tissues adjacent to that K-wire, especially on the radial side of the wrist, where the radial cutaneous nerve runs, and on the dorsum of the wrist, where the extensor pollicis longus tendon runs. Any dissection in that area and putting a wire in the dorsal surface of the wrist or the radial side of the wrist, we have to be very, very respectful of the tissues. And we can use threaded wires, we can use the Kapanji technique, which is passing the wire very dexterously into the fracture and using it as a lever to hold. AO 1958 started defining and classifying fractures, and classifications are completely useless, as we all know, unless they make a difference to the patient. If a classification is useful, it will make a difference to the patient, and that's where AO has really moved things forward and shown us in controlled trials, blinded trials, certain methods are better than others. And this is just what Lauren was saying. Think about blood supply, conserve blood supply, fix in a stable way as possible, preserve the blood supply, and then go for early movement. Obviously not that sort of movement if you've got wires inside you, but once your wires are in, and the patient's pain is going down, really, really encourage early movement. Finger stiffness after Colley's fracture, or Smith's fracture, or Barton's fracture is very much the biggest problem we faced. And the patients come to you, they almost like absolve all the responsibility for their fracture, and they give you the responsibility, and they'll say, it's still stiff. And I think it's very important to get that message on from day one, that it's a mutual effort. They have to work as hard as you do to get them right, if not a lot harder. And to get the message across the patient, they cannot absolve all responsibility. They must do the work. They must do the physiotherapy. An exercise sheet is worth $1 million. A diagram of exercises that the patient can go at home, and they'll come back so much better off than coming back with this rigid claw hand when you take the wires up. They'll already have the movements back. Just showing the various techniques, which we all know. Just respect for that nerve. A lot of problems with that nerve. You wind that nerve around the wire, and the patients will not thank you for the rest of their lives. When they tap the radial side of the wrist, they'll have that horrible electric shock from the neuroma. So be very respectful of any wires going in onto the radial, any incisions in this area, whether it's for the Krabbe, whether it's for scaphoid fracture, whether it's for radial styloid fracture. Be very cautious. It's a source of great litigation, certainly in my country, in UK, for people that haven't shown enough respect for that area. Just because we've got it in the cupboard doesn't mean to say we need to use it. It's an advance. There are now papers, like everything in orthopedics, that goes full cycle. Everything in the olden days was treated conservatively. Now, because we've got this molar locking plate, everything is treated the other way. We are forgetting our techniques of Sarmiento and Charlie of plaster treatment. We must not forget those techniques. They are the cheapest, they are often the most efficient, but if there's a great deal of instability and you're not going to win with a plaster, you can start thinking this sort of plate. A lot is made of these locking perfect. All you need to do is open very, very carefully, put the plate on, and as long as the fragments are not too far displaced, leave the periosteum intact. And just literally, as you tighten, if you can get the screw and the plate at the correct level on the X-ray machine, as you tighten your diaphyseal screws or your metaphyseal screws, the plate pushes all those fragments in this wonderful way, and we've all seen those fragments. Those look very, very comminuted, but by leaving the periosteal sleeve intact, you don't need a very sexy plate to get a beautiful result. So for pounds or relative dollars, very few dollars, you can get a very good plate fixation of this radius. These plates are more costly, but I think they will obviously they're becoming more common in the very difficult cases where you want to do fragment-specific fixation. You can see the radial styloid is displaced. You can clamp it percutaneously and then put the plate on with a locking screw that holds the radial styloid in a more favorable position. All the dorsal fragments in a better position. That's just an example of that fracture's been plated, but if you criticize it, you can see that's not out to length. That probably was a delay fixation. But if you look at that, there is ulna plus. That radius is still short. And I find them quite scary. If you do your post-operative x-rays and you look at that screw there, which is clearly going up to the radial styloid, and you think, my goodness, that's very close to the joint. Leave a screw in a joint, and you've done that patient no favors. That quite clearly will be destroyed, that joint. Just a slide to look at the sort of the results we're all looking for. We want early movement, we want a supple joint. There are people who've written about arthroscopically assisted reduction of nine-punch injuries, where they literally have a scope in situ, they elevate the fragment in a very dexterous way, put some bone graft behind it through a little mini open incision, and then percutaneous wires to shore up the more complex fractures. Not something I've ever done, but in difficult cases, something to think about. I mentioned some of the tricks of the volar plating. It's the common approach through the web of FCR. It's the protect the radial vessels and the median nerve, as long as there's not too much tension. I call that the meat shredder, the self-retainer. If you're not careful, you can really damage tissues with self-retainers, we all know. It's a delicate approach. Take the radial side, take the median nerve, expose the fracture, apply the plate, and then fix it. got a lot of soft tissue damage, they obviously have a role to play because you're not very metal work.
You send them somewhere. What do you do? You don't go beyond into the nerve and vessels which are over at the other side, just to within the fracture. Right, so what you do is to pull the fracture apart. What's the deformity you see in Colles fracture? It's like a dinner fork deformity. The bone is sitting at the back dorsal part and angled towards the sky. So now, can you hold that? You can give counter traction. So you wait for some time for the lucernus to work, and you get hold. This one. Catherine, you are going to minimize the patient from flying out. Okay? So you keep gentle, firm, continuous traction. You will see the fracture move. It will pull fracture. Sometimes it doesn't go back fully. You know the fracture is tilted this way. So, let me then demonstrate what you do after. Are you strong?
Yeah.
Okay. So you pull with your palm or your thumb. You're going to push this fracture down. That's right. Correct it. That it tends to actually angle it towards the radial side. So two forms, one towards the palm and the other that way. Okay? Right, can you do that? So we really send these fractures to the plaster room girl. She doesn't know anything about it. All she will do is to slap the plaster on. Yes.
In my experience, most of the time I see them after a week or 2 weeks.
Yeah.
And I refer them to the
Come a bit late.
specialist. Yes.
But the reason is that your medical assistants and others refer them straight to the plaster room. And the plaster technician just put the plaster on. There's no manipulation. I'm talking from my own past experience. So the patients come to you with a deformed wrist. and they go to Dr. Rahman, it's a bit too late to do anything. So we're going to do this in our hospitals. It's very easy to manipulate. Okay, so you pull, you cannot do it on your own. You need assist, you need people to help you. 3 people. One is the one applying the traction. The second is the counter traction. And the third is going to do what? Apply the POP. Right? Okay, but meanwhile you leave one person in the cluster room to do that. That's not quite right. So go on. You're reducing the fracture. You are disimpacting it now. And then you maintain the traction. And, well, maybe with your left hand here, you're right-handed. You're going to push this towards the palm. And with the thumb again, you're going to correct the angulation towards the real side. Then once you think you've reduced it, you can relax it. You can leave it. And you can take a look at it. Now, how do you know whether you reduce it or not? The deformity, if it's corrected. And how else? With your fingers, the ulnar styloid usually is not as prominent or as it's not distal as compared to the radial styloid. So if you put your index finger on the radial styloid and your thumb on the ulnar styloid, the radial styloid will be more distal. Then it's more than likely you have reduced it. If you're not sure, go for the proper arm and compare. Okay. So how are you going to mobilize it? Plaster. How do you apply your plaster? You haven't done it, isn't it? No, I'm talking about from my own experience. I never did it. The plaster. So how would you do it in this case? Are you going to go above the elbow? Are you going to go below the elbow for a simple collis fracture?
Below the elbow.
Fantastic. Now, how do you make sure that the plaster keeps the fracture in good position? And you spoke about the Charlie's contact, pressure points, 3. If you apply a plaster which is a tube, yes, the plaster can fall off. So the shape of the plaster can help you. The plaster can look very ugly, but it can do a good job. The fracture is displaced this way and that way. You need some force to counteract that once you push it back. So there should be one point pushing the fracture down. So if you push the plaster down here, there will be space here. So there will not be compression. If you did that, you are actually crashing it.
Okay.
So one pressure point here, the other pressure point there. And of course, the shape of the plaster will be such that it's not tubular. So it won't drop off. Okay. Any questions? So how are you going to numb the fracture? How are you going to numb the fracture side? You can give leucanescent. You want to make sure that the leucanescent goes to where the fracture is and not anywhere. So you put a little in, you got to clean the area. Don't convert a simple fracture to an open fracture by putting bacteria inside. You got to clean the area. You get any questions? Yes.
We are seeing these patients on the first day.
Yes.
Are you doing this manipulation?
Yes.
But if you apply the POP,
Very good question. Now, why do we apply POP and not fiber cast straight away? POP has a little bit of give. But if you go apply it completely, if there's swelling or you anticipate swelling, it will compress the soft tissue. So you start with what we call backslab. It's a half plaster. And when you apply the backslab, make sure the wrist is free. Don't apply the plaster to include the whole fingers. So up to there, so the patient can bend those joints. So half plaster, okay, making sure that the plaster has free space for the thumb. Okay, and up to there. So it should be sitting at the back here and you compress. When the patient comes back, the swelling has gone down, then it can complete. Yeah. Alright, yes.
So when is it advisable to attempt manipulation and reduction?
The patient comes to you with a fracture straight away.
But because if the patient doesn't come the first day,
They come to you, you have to manipulate.
after 1 week,
And because reduction of the fracture provides pain relief. Reduction of the fracture minimizes swelling. Okay? So you should do it straight away if you can, as soon as you can.
What I want to find out, if the patient comes after 2 weeks, can you attend?
Yes. When you
What
see
about
the
1 week?
patient, whenever you see the patient, you should attempt to reduce it. If you're unable to reduce it, maybe it's too old and somebody else can deal with it.
My problem is, can the back slab put the reduction in place?
It's a temporary agreement, but if you put a counter in the plaster, you should hold it. But there's bandage on it, yeah, you should. Any more? So we're going to try and reduce this fracture when they come to us. We may go with the patient to the plaster room and support the plaster nurse to get the proper thing done. All right?
Okay, because our population is ageing now, so it's getting more and more common, and we'll see probably about 5 or 6 of these a week. We talk a lot about patient pathways in London, and that involves the actual fracture itself, but also assessing why the fracture's happened, then thinking about how you're going to treat it with an operation, then going on to how you're going to rehabilitate the patient while they're in, so physiotherapy and occupational therapy, and then looking at trying to stop them breaking another bone, and then long-term care. And often in the UK that means perhaps putting them in a home or getting nurses in to actually help with their management as well. So you'll have to think about how you'd adapt that here for Ghana. With preoperative assessment, we need to find out why they've fallen. Have they tripped over the carpet? Are they still using stairs when maybe that's not so good at their age? Are they having problems with their balance? Have they had a stroke? And can we try and stop them breaking something else again, which might be more fatal? There's several different types of hip fracture, and broadly speaking, we just classify them as stable and unstable. If you want to go into more detail, there's Gardner's classification, which is stage 1 to 4. So 1 is an impacted and complete fracture, 2 is a complete or undisplaced fracture, 3 is a complete or partially displaced fracture, 4 is complete and totally displaced, and then we go on to extracapsular fractures, which can be intertrochanteric, so between the trochanters, subtrochanteric, which is below, and then reverse oblique, which is at the opposite angle to what you'd expect. We use a reduction table in the UK to try and reduce the fracture, and we put the traction on to stretch the bones and the ligaments out, and then twist the leg one way or the other, and sometimes cross the legs or uncross the legs in order to reduce the fracture. So that's very useful if you've got them here. There's lots and lots of different treatment options available to us. So we can use cannulated screws and dynamic hip screws. We can use intramedullary nails, or we can actually replace the broken femoral head with a hemiarthroplasty or a total hip replacement. In the worst case scenario, you can go onto a girdlestons, which would just be to try and get rid of the pain, or analgesia and traction. And at the end of the day, if the patient is very moribund, you may consider this an end-of-life event and just make them comfortable. Intracapsular fractures are undisplaced or minimally displaced, and they can be treated with cannulated screws or a 2-hole DHS. So especially in the younger patients, you may consider this as an option to try and get them on their feet and back to work as quickly as possible. They need to be able to comply with non-weight bearing for about 6 weeks, so that also needs to be taken into consideration. Intracapsular fractures, where you have a complete fracture, you can think of a hemiarthroplasty or a total hip replacement. And then you've got lots and lots of different types of intertrochanteric fracture. So think very carefully about the fracture pattern of these and consider the medial buttress. So if you've got a large bit of the medial cortex which is missing with the left trochanter, then there's not much to actually fix everything back onto, and they can potentially be quite unstable. In the majority of these cases in the UK, we'll use a dynamic hip screw. There's a picture of that on the screen, and very occasionally a proximal femoral nail, and the jury's still out as to what the best is. Probably the DHS is easier to put on. Subtrochanteric fractures can be very difficult to treat, and again that's because you don't have much of a medial buttress. Often with these we treat them with an intramedullary nail and consider open reduction to try and get a better position of the fracture fragments. What you'll find is that the psoas tendon will often pull your proximal fragment up and make it very difficult to reduce close, and often you're just better not wasting time opening everything up and just seeing it with the naked eye and reducing it. And you can then supplement your fixation with cables and wires. They're a difficult fracture pattern to treat. With the reverse oblique fractures, you can see the angle of the fracture goes opposite to in all the other fractures where it's intertrochanteric. And these are very difficult because the fracture tends to go into a varus position anyway. If you fix it in a varus position, it will fail. And you can see that from the previous one where it's been fixed varus and shortened and the screws are just cut out proximally. So think about very low thresholds for opening these. You can sometimes put a wire around if you're not happy with the fixation. Use a traction table and think about bringing the leg out into abduction to try and get a better position of your fracture fragments. And then they're often difficult nails to do. Other options with a reverse oblique, you can use what we consider old-fashioned, but is actually a very good fixation device, a blade plate or a nail. And as you can see, again, often these fail, so you've got to really follow them up and watch them like a hawk. Secondary prevention in the UK, there's a lot of osteoporosis. It's probably because we don't get much sunlight. So we'll think about calcium bisphosphonates, and as I said, a falls risk. So very simple things, just look at the footwear. Are they wearing high heels or slippers, which makes it obvious that they're going to trip over again? Are you better off getting them into trainers or something a little bit more stable? Look at balance. Are they having problems when they close their eyes and they're falling over? If you address their balance issues, you might stop them falling over and breaking something else. And then think about walking aids, so walking sticks and frames to help them mobilise, and again try and reduce that risk of them falling again. Any questions? I just kept it short and sweet. I don't know what you do here.
What's our experience over here? This sort of fractures.
Yep.
If it's a young person, because of the risk of having avascular necrosis of the head or the femur, we try to put in screws.
You won't hold out the screws.
Okay, no, I'm just trying to, because we often get most of these fractures over here, especially more from women, because of osteoporosis. And our experience here is either to put a DHS, which is our choice, because we don't have this gamma nail or interlocking nails or PFM or so. So we try to use either the angular plates like this one or the DHS.
So I think the angle plate's good because you've got a really rigid fixation up here. If you're going to use DHS, then you use a very long one because the force on your fixation is here, and the DHS is really designed to collapse it. It's more for fracture, well, for more proximal fractures up here. So what you're relying on with your DHS is really just the screws down on the plate. So perhaps make it a longer plate and then hope that that's enough to hold it. Again, it will depend on the quality of the bone. They're really difficult fractures. And even in the UK, where we've got everything to choose from, often they fail. The other thing to think about is, are you better off replacing? So sometimes with again, fractures which we would try and fix. So some of these fractures, because we'll get them quite early, so they'll come in probably on the day or the day after their fracture, it's easy for us to again treat them with just a tip of DHS or screws, and we know that they've got a good chance to heal. But if you're seeing them maybe a week down the line, you may be better off just going for having arthroplasty straight off or a total hip replacement if the patient's younger. And again, in the older patient, if you're seeing a delayed presentation, you may think about a girdle stunts if it's just purely for pain and getting them back out and mobilising. But again, I mean, we certainly find with the girdle stunts, they don't mobilise as well as with a hemiarthroplasty. And again, with all of these fractures, we get them out of bed as quickly as we can. If you keep an old person in bed, they get chest infections, they get pressure sores, and a lot of them will die. And the main aim at home is to just get everyone out of bed, mobilising out of hospital as quickly as possible. Partly because we've got no beds, so we're just trying to get people out so we can get people in. Have you got any other questions?
came and made that they just do the Geddy stone that she's talking about. You remove the head of the femur from it, and then it's supported by muscle. But later on, the other option that we have, which is a bit cheaper, is the osteoprothesis of Thompson and of Thompson prothesis. We'll remove it, the head, and then we'll fix the more prothesis. That's financially a bit cheaper than the total hip, which costs a lot. So that one, the following day, you're able to mobilize the patient to walk on the leg, and then it's far better than the Geddy stone. Because the Geddy stone, when we are having problems with Geddy stone now, those that were done about 4 years ago, and you want to put on the total hip, they easily displaced, they are dislocated, because the muscles have been contracted and don't have. So to be able to pull down the leg to the normal level to fix the prosthesis becomes a very Herculean task. You can fix it, but the moment the fellow does the leg like this, it just pops out. So that's the problem of having Geddy stone. So it's not advisable, to be honest. The other option is to go for the osteomore, which is a bit cheaper.
And it's easier.
It's easier. You just take the head and then knock in and then push it in.
And they're quite forgiving as well, because the head's so big, they're pretty stable. So if you get the rotation slightly wrong, it probably won't dislocate.
So now we advise people with elderly people, instead of the Geddy stone, go for the arthroplasty. So that is it.
You say cheaper, how much?
The cheaper compared to the total hip. The total hip costs between 10,000 to 12,000 NSC.
Just for the prosthesis?
Yeah, for the prosthesis. That's a long lasting, okay? And depending, because there are so many different models. Some from Striker, Dupuy, and those, so depending the company. But the one that we feel is a bit cheaper is about 2,000. 2,000, that's the hospital.
Also, often with the older patients, they're quite sick generally, so you want a very quick operation, and an osteomore you can put in 20 minutes. A hip replacement will probably take you an hour or longer.
And with the total hip, the problem is that they don't come so early. They come with problem with the acetabulum. So fibrotic and very difficult to clear up. And sometimes they have mini fractures in the acetabulum, so you have to have a cage, and that makes it even more costly. We don't get the cases fresh. Like this issue about this college factor we're talking about, if you go and look at the tariff for the NHIS, there's money in manipulation and application of POP. So if you can do it at your end, instead of sending, you can get a lot of money from that. Okay? It's very simple to do it. Instead of seeing the patient, so this and this, you push the patient to come. You can do it yourself. The issue they already explained, even if it's 2 weeks, sometimes they come a bit. We try as much as possible to see. We are lucky to have a plaster room who are experienced, 20 years experience. So they are able to handle. But with you in the district, that you don't have the luxury for a plaster room, you the doctor should be able to do it. You do the infiltration, you reduce, manually reduce, apply the POP, and do another check X-ray and see. And then you can let the fellow go and come back. The only thing you have to be very careful that you don't have compartment syndrome, because if you apply it so hard, then the compartment syndrome sets in, and that's catastrophic. You can end up, the fellow can end up missing the leg and the limb. So you have to be very careful, but you have to try. You have to try. Because if you look at the tariffs, there's money, I think about 200 and something for that one alone. So the ball is in your court. It's not every time St. Joseph's. Yeah. Okay. 15 years and it's a bit more hard. At least, let's say, before it will last the fellow dies.
It depends a little bit on the quality of the cartilage in the acetabulum. So if you've got reasonable quality cartilage and they're low demand patients, then they'll do all right with an osteomore, and that's enough. But say if you put it into a 60-year-old who's going to walk around, because you've got metal on cartilage, they'll wear through the acetabulum and it'll cause pain.
If you reduce and then you apply the POP, then you do your check X-ray, and it's not well aligned, what do? You can
we have acceptable alignment that you can say, okay. But if it's grossly displaced, then you have to change it again. You have to redo it.
There's no harm in redoing it. And also admitting them overnight if you can, just to get the swelling down. Amazing ability sometimes just by elevating overnight in that position. You'll have, it's rather like we'll talk about children's fractures. The swelling is the big enemy and it causes some great pain. Once the swelling goes down, it's much easier to deal with. You can feel where the bone is when the swelling goes down. So yes, but I think the answer is you can get away with a little bit of dorsal angulation. What you don't get away with is rotation and displacement. And the intra-articular one is a little bit more complicated. If it's an extra-articular fracture, you've got it reasonably aligned and you've molded the plaster, as long as the next one that's put on in a week or two's time is slightly molded, you'll hold that fracture. If you put on, just as Paul said, a tube, a cylinder, as the phrase goes, straight plaster, crooked arm, bent plaster, straight arm. If you mold your plasters nicely, you will hold that fracture quite commonly. As we all know, the Ebola ones, the Smith's fracture is very difficult, and patients will be quite intolerant of having to be stuck in a valve elbow cast for too long. And they'll be complaining miserably because they're walking around, people are laughing at them with their peculiar shaped plaster on. But they are difficult to hold. We don't do them, our patients won't tolerate it. But I think if you're in a rather rural situation, there's no harm in trying to hold a Smith's fracture in a plaster.
We've probably also lost the skills because we operate on so many, whereas you see so many and you're manipulating them that you'll get really good.
Only by doing it do you get good. Swollen situation. Your anaesthetist will be saying, come over here, I'll help you. A little ultrasound here, and they'll see the nerves, and they can numb the nerves higher up, so they'll give the patients enormous relief, and then you'll get much better pain relief while you're reducing the fracture. But if you get less pain relief, the patients resist less, and you can reduce the fracture much easier. So anesthesiology, it's a team effort, just as you rely on the nurses to pick up complications, so you rely on your anaesthetist to work with you as a team. And my chap does these, because I do a lot of shoulder surgery, he does a lot of ultrasound-guided interscaling block. So ultrasound-guided block will be very useful to give the patient appropriate analgesia. Rather than taking them to theatre, you may even consider doing that in a casualty environment.
Do you get a lot of
Cannulated screws, because the physios are sometimes, and the nurses are not sure sometimes whether to allow the patient to be fully weight-bearing or partial weight-bearing.
if they can tolerate non-weight bearing, you keep them non-weight bearing for 6 weeks, but if they're very frail and you know they're not going to put much weight through the leg anyway and to help them get out of bed, then you probably say full weight bearing transfers or partial weight bearing. So you kind of gauge what the patient's like. The main thing is to just get everyone out of bed. There's no point keeping patients in bed for weeks because they'll just die from a chest infection and bed sores.
What we try, our experience, one could have translated screens. The following day, we will let them to now. In fact, we have a well-organized physio department. So they take over and they know what to do. So the little will operate and they'll say, refer to physio, and they know what they are about. So when we are discharging them, we give them an advancement that we come back in 6 weeks for review. And then we decide whether they can then start the partial weight bearing or full weight bearing, depending on how the clinical findings.
The other thing with this patient group is to get them into surgery as quickly as possible. So again, in the UK, we're driven by tariffs and targets, and we don't get paid if they're not in and have their operation within 24 hours. We get penalised. So that's another thing to think about. Often, if they're sick when they come in, you can't make them any better, and you're better off just getting them operated on, and then you can mobilise them, and it's better for their chest.
Yeah, with your experience here, you get them fresh, we don't get them. The earliest we get them is about 2 months after they've gone to the herbalist, and they come with other complications, so it takes time.
The leg is already quite short.
Yes, short is already
adapted.
And that's such a different patient group, and with those, often all the things that I've said, there's no point doing, and you can probably cause more harm.
There's a possibility it will be the same, because you have to do the osteotomy, remove those things, and then you try to fix it. And then maybe you can give some length back if you are lucky, okay? But if you are not lucky, they still have discrepancy. And we try to offset that one with this raising of the shoe, so we'll direct them to the workshop. At least we'll let them have that thing in mind that there's a possibility that this will happen on this. Otherwise, people are such that psychologically, they feel we can fix everything.
Yes, high expectations.
Yeah, high expectations. So they become disappointed that it came with a shortened leg and it's still with a shortened leg. So we try to put that again that it's possible we can gain. But some, obviously, will be able to gain the leg back by using these iron bays. We're knocking the iron bays with a locking. These puncture nails, we have the puncture nails. And the locking is a bit more expensive. So we'll use these puncture nails and then I'll be able to get some leg back. So that's our experience.
It meant it be a shortcut presentation because of how well you have done your talk. What is fracture union? There's a clinical union and there's neurological union. You know it. What did she say? No pain, no motion. Yeah? What about the neurological union? Fracture, colors across the sides. So you know all about it. What is non-union? It's a very debatable definition. I remember one of my senior bosses before, he did question me to define non-union. And he said, if the fracture hasn't healed 9 months and a day, plus 1 day. I said, well, of healing over 3 months period in a long bone fracture, it's worrying. So what do you think is happening here? It's a supracondylar fracture of the femur, which an attempt has been made. Is it united? What is there? It's a gap. And they are not serving any purpose. Which is about 9 months. A comminuted fracture in various pieces, which is, I think, approximately 11 months old. Again, picked up from this country. Most of this patient actually was a gunshot injury. I think AK-47, I'm not so sure whether it was AK-47, whatever it was. Non-union is seen in the long bone. I don't know which one heals better. Is it the femur? Is it the tibia or the humerus? Humerus heals better. Okay. All right. The requirement for union, you must have living bone. The bone is there, you're going to leave it behind. Don't expect the bone to heal unless it's being used as a graft. As a graft to encourage scaffolding of knee bone into it. So dead bone actually is not helpful. Lack of movement. Absolute stability will be helpful. If there's a big gap between the fracture ends, no matter how stable it is, it's not likely to heal unless you aid it with some graft or some form of encouragement is given. If the local biological factors are inappropriate, inadequate, you're not balancing it well, of course, it means that the fracture union is going to be difficult to achieve. This is what Gettystone said. I'm sure you will have heard about Gettystone.